On completion of range of motion, we might go into muscle length testing. Now, gastrocnemius and plantaris are two joint muscles that need to be considered. So, dorsiflexion of the ankle should be assessed with the knee both flexed and extended, as gastrocnemius and plantaris both cross the knee joint. The other muscles, the muscles that go down to the toes, again, they are multi-joint muscles. So, by combining ankle dorsiflexion with toe dorsiflexion or ankle plantarflexion with toe plantarflexion, we can differentiate between tightness of individual muscles. Muscles like extensor digitorum longus, extensor hallucis longus, flexor digitorum longus, and flexor hallucis longus as well. When we go on to manual muscle testing, there's a number of muscles that we should be assessing. Gastrocnemius and plantaris can be assessed by resisting plantarflexion. Now, these are very strong muscles, and so to test them against gravity, anti-gravity testing, as opposed to gravity-modified testing, you'd need to have the individual either in standing or in prone lying, where you can apply your weight effectively through the lower limb. For gravity modified testing, we would do this in side lying, and you resist the movement of plantarflexion. The same is true for soleus. Soleus works very closely with gastrocnemius and plantaris. When we look at muscles like tibialis anterior, this is a dorsiflexor and inverter of the foot, and so we test dorsiflexion in either in sitting with a knee flex hanging over the edge of the bed, or in a gravity modified position we would do this inside lying. Tibialis posterior, again against gravity, we would test inversion and plantarflexion inside lying, so the individual is trying to lift their foot away from gravity. And gravity modified, we may place the individual in supine lying, and the same is true with peronei, obviously lying on the other side. These are everters of the ankle. Now, the peroneus longus and brevis, will also plantarflex the ankle, so again you may want to combine the movements of plantarflexion and inversion to help you differentiate between muscles such as peroneus tertius and extensor digitorum longus. Flexor hallucis longus and flexor hallucis brevis need to be tested. You've got to make sure there's adequate strength and assess the integrity of the flexor hallucis muscles, as is the case with flexor digitorum longus and brevis. Extensor hallucis longus is done in supine, getting the individual to dorsiflex. Extensor hallucis longus is quite an important one to test because that also assesses not only the integrity of the muscle itself, but we often use it to assess the integrity of things like the L5 nerve root in particular. There's a whole number of intrinsics in the foot that you may want to test. The important ones being the aboadductors of the big toe and the lumbrical muscles themselves. And these are done by obviously aboadducting the big toe, or doing the typical lumbrical action, which is the movement of flexing the metatarsophalangeal joint whilst maintaining interphalangeal extension. Palpation is often done to identify any bony tenderness in particular and suggest any indication for fractures. In particular, it's important to palpate the malleoli, the sesamoid bones that sit underneath the great toe, and the calcaneal tubercles in particular, which sit around here, so the posterior inferior corner of the calcaneum. The styloid process on the base of the fifth metatarsal may also become avulsed or fractured, so it's important to check that. In terms of palpating muscles, the important structures are the Achilles tendon and the peroneal tendons. They are very prone to irritation, but also the muscles that pass under the flexor retinaculum, so tibialis posterior, or the anterior tendons themselves. Plantar fascia may need to be palpated. The most common site of irritation of the plantar fascia is back here at the calcaneal tubercles, in particular at on the medial side itself. If neurological testing is indicated, the myotomes that are of greatest significance is dorsiflexion of the foot, which is suggestive of L4 compression, dorsiflexion of the big toe, which is suggestive of L5 nerve root compression, ankle plantar flexion weakness in the ankle plantar flexors would indicate S1 compression, and S2 may be as a result of weakness. S2 compression may lead to weakness of toe flexion. Reflexes, the reflexes that exist around the ankle that we can test are the Achilles tendon tap. So we can tap the Achilles tendon, which helps us assess the integrity of the S1 nerve root. There's a number of special tests that we do at the end of the objective assessment, or towards the end of the objective assessment, and these special tests are often indicative of certain structures. So things like the anterior draw test, Taylor tilt, inversion stress test, and Thompson test. Palpation, again, is often used as a confirmatory tool, and then functional tests, as mentioned earlier, must include gait and its functional progressions. Scans and x-rays may be viewed at this point, or may be indicated at this point. So going on to the special test. Assessing the mobility of the neural structures is important. The tibial nerve can often become involved as it passes underneath the flexor retinaculum. The superficial peroneal nerve may become involved as it passes over the anterolateral corner of the ankle itself. So doing a straight leg raise with dorsiflexion to assess the mobility of the tibial nerve is important, and then plantarflexion and inversion to assess the mobility of the peroneal component of the sciatic nerve. The wedge test, or sometimes called springing of the ankle, is where the talus is forcibly dorsiflexed into the mortise of the ankle joint, and that's a fairly good indicator of ankle dysfunction, ankle or inferior syndesmosis dysfunction. And a fairly important test is something called a Hohmann's sign, or a Hohmann's test, which is a test used to indicate the presence of a deep vein thrombosis. In this situation, the individual is laid supine, the knee is held extended, and the foot is passively dorsiflexed with overpressure. Pain in the calf may indicate a deep vein thrombosis, although it can also be as a result of other structures. So injuries of the gastrocnemius complex may also lead to pain in this situation. The anterior draw test, as demonstrated here, the operator would stabilise the lower leg, the tibia and the fibula over here, and they draw the whole foot anteriorly. What we're looking for is movement of the talus out of the mortise, and sometimes the presence of a sulcus sign, a sudden hollow appears anterior to the malleoli themselves. This is to assess the integrity of the anterior ligaments of the anterior capsule, and 2 millimeters. More than 2 millimeter left to right difference is often indicative of some form of ligamentous disruption. Similarly, a posterior draw test can be performed to assess the integrity of the posterior ligaments. These are far less commonly damaged, and the test itself is far less indicative of ligamentous damage. The syndesmosis can be assessed by doing either the squeeze test, in which over here we can see the fibula is squeezed at the top, which creates a distortion of the syndesmotic ligament and creates pain down here, or an external rotation test here, in which the subject is in high sitting, so sitting with their legs over the edge of the bed, and the foot is forcibly externally rotated. And as we externally rotate it, the talus rotates in the syndesmosis itself, and it can cause pain. The Taylor tilt test is to assess the integrity of the lateral ligament complex, in particular the calcaneofibular ligament. So if we see a tilt appear, fairly large tilt appear here with a gap, this is actually a stress x-ray, so a tilt of 10 degrees or more is indicative of a rupture of the calcaneofibular ligament. And then there are various amalgous stress tests in which it assesses the integrity of the subtalar joint and, again, the calcaneal ligaments. Thompson test is a special test that's done to assess the integrity of the Achilles tendon. A ruptured Achilles tendon would lead to a positive Thompson test. So in other words, the operator here squeezes the calf, as we can see here, and as a result of that squeezing, what we should see is plantar flexion of the foot. Now, if the Achilles tendon is ruptured, what happens is when we squeeze the calf, the ruptured portion of the Achilles tendon just rides up in the calf itself, and there is no plantar flexion of the foot. Morton's neuroma is an impingement of the digital nerve between the second and third metatarsal head, and direct palpation here would often lead to acute pain. And as we can see here, direct palpation with a squeeze occurring, squeeze between the metatarsal heads, again can create pain. And Morton's neuroma is a fairly painful condition. In terms of functional tests, there's a wide range of functional tests that we can do. We can assess gait. We can look at people walking forwards, backwards, tiptoes, heel walking, wide strides, narrow strides, long strides, short strides, as it creates different stress on different parts of the foot and ankle. Squatting and lunging is often quite a useful test, and going into a single leg squat or a single leg hop is often slightly more stressful, significantly more stressful. Progressing on to higher load and higher speed activities such as running, change of direction and speeding up, slowing down, often tells us whether there are high stress problems present. We progress through these functional tests. We don't do all of them. We don't necessarily need to do all of them. I mentioned earlier about the possibility of a fracture. Now, there's a group of rules called the Ottawa ankle rules, in which we palpate certain areas. So palpate the posterior edge or the tip of the lateral malleolus, or the posterior edge of the tip of the medial malleolus, and an inability to weight bear either immediately or at clinical presentation. This is indicative of a fracture. And may require an x-ray. If there's any bony tenderness at the base of the fifth metatarsal or tenderness at the navicular, and again an inability to weight bear, again may also indicate a fracture. These rules are often applied at accident and emergency as primary indicators of the need for an x-ray. So to summarise, you start off by deciding whether this is an acute or a chronic injury. Identify the nature of the injury itself. If it's chronic, you need to identify the faulty mechanism. So is it because an individual has got an abnormal gait pattern, excessively pronates, excessively supinates, whether there's been any previous injuries that are leading to this problem. You may need to refer on for specific foot pathology. So, for example, the inclusion of a podiatrist as part of your multidisciplinary team may be an essential component.